Are you able to see?
Right.
Yes.
Great. A radiograph and a CT. Great. So this was just a cute, classic imaging finding that I just came across today in this patient, because this patient just came in for a repeat chest CT. But on the radiograph, I think we see a very classic sort of Aunt Minnie appearance, which is this linear structure here in the right lung, which is sort of, at least on this radiograph, looks like it's coming from sort of the mid portion below the fissure here, and then coming down towards the hemidiaphragm. And this is just a patient with a classic scimitar vein. And this patient is actually in their 80s, and they're coming in getting their chest CT because they have shortness of breath. So here we can see that vein nicely draining into the supradiaphragmatic portion of the IVC. And if we track it back upwards, right, we can see that it's draining, honestly, the majority of the right lung. If we come back to the right or to the left atrium, we see that there's not really any normal veins draining into the atrium on the right-hand side, but the left-hand veins are normal.
It looks like there might be a tiny one inferiorly.
Yeah, like this little squiggly guy.
And there was another one right
this
there.
This one down here, yeah. But the vast majority of the lung, it looks like, is being drained by that scimitar vein. And this person obviously has, very enlarged right-sided heart chambers. Their main pulmonary artery is big. It looks bigger than their aorta here. So they probably have some pulmonary hypertension. Their liver looks a little bit kind of nutmeggy. So probably pulmonary hypertension. That honestly, I would suspect, is maybe the cause of their shortness of breath and their symptoms, and maybe related to this long-standing scimitar. So
what's their airway anatomy look like?
That's a great question. So it does almost look like, I'm going to switch back to axial here. So trachea coming down. It looks like kind of bilateral left branching.
It looks like they're missing some segments, as they often do.
Exactly.
And how many fissures do we have on the right?
Right-hand side.
We have one weird fissure.
Yeah, we get this one sort of like squiggly looking fissure.
And there's
Yeah, it's kind of just the one.
Yep.
Yeah. So nice.
Has anyone ever figured out why this only happens on the right?
It's a great question.
I've always wondered that.
Yeah. I do not know the answer to that.
There's probably a sexual reason if Felsen has chimed in on it.
That's a nice one.
Yeah. Anyways,
it doesn't have. I didn't see systemic arterial supply.
No.
Which is another common thing we've seen.
Yeah, looks like.
And then sometimes some weird diaphragmatic slips. But yeah, this one. That's probably why they made it to with their 80 whatever.
Exactly. All right, so that was that case. The device. So here's this patient's chest X-ray, right? Obviously, this person has a left ventricular assist device, and whenever we're worried about these, oftentimes the thing that we're most worried about happening in patients with LVADs are going to be driveline infections, because the driveline obviously is the thing that goes outside of the body and connects this device to the external world. And so this patient was coming in with concern for driveline infection. So here, if I start down the bottom of the abdomen, we can see that driveline in the subcutaneous tissues. And as we come up, we start to see this fluid collection around it. Definitely concerning for infection involving that line. So I think, it can be easy to just see that and be like, okay, there's a driveline infection, but it's also important to make sure that we know where that is extending to if they are going to go in and try to treat this. So if we actually follow it all the way back, we can see again a little bit of fluid sort of above it. But if we come back to the device itself, right, as we come down, we see this pocket of fluid at the bottom of the device. And if we go all the way up, we see a pocket of fluid at the top of the device. So it's sort of wrapping around this device. So there's this abnormal fluid collection involving the driveline as well as the pump device itself. And that's not all. We have to keep following the whole device. So here is our outflow tract. And as we come up outflow tract here, we also see a pocket of fluid next to the outflow tract as well. So this fluid collection is extending along basically the entirety of this device. But again, satisfaction of search, that's not all that's going on. The other complication that we often get with LVADs is outflow tract stenosis, and we can see that there is some eccentric thickening here inside the lumen. And if I zoom in here, right, we can see this thickening that's almost 50% of that lumen. And so this patient did have clinical signs of stenosis in their outflow tract. So this patient basically has all of the complications one can get from an LVAD at the same time.
Wow.
So they have to remove it.
I think that they went in and like debrided a bunch of stuff. I don't know if they actually removed the entire device,
Okay.
but I think they went in and did a bunch of washouts for this patient. So, anyways, those are my cases.
Thanks.
Thank you.
David, feel free to go.
Okay. So seem to have to do this every time. Let's see. How do I?
We see your screen.
You do? You see
Yes.
a chest röntgenogram?
We do.
Okay. Notice this elongated thing here in the right apex. So this is a sort of exaggerated example of this phenomenon. You guys know, are you familiar with the Proto's apical opacity sort of thing?
Mm-hmm.
Okay, so this is actually caused by an impression from the right brachiocephalic vein and sometimes the subclavian or carotid vein. So this is the article by Proto. Can you see this now? Let me bring this up.
Yep.
Can you see the Proto article here?
Yep.
Yep.
Okay, so here are his examples. This is back from 1986. You can see in this one, it's more of an oval, which is a typical thing. It usually has sort of vague borders to it, not very crisp. And there are other examples here. Let's see. Here are some smudgy examples and some counter examples too of other things that can do this to get in the way. Here's the lone CT scan in this thing that shows the indentation on the anterior lung from this brachiocephalic artery and subclavian complex up here. So it's these vessels leaning into the lung that cause that oval and in this case tubular opacity in the apex. So just because this is a benign cause of an apical opacity, be aware of other causes of apical opacity such as tumor and infection. But this I thought was a nice example of the apical opacity of Proto up there. This is more elongated than you usually see. I don't have a CT for this case. It was an outside exam sent for a B reading, which was normal. Okay, and then I'd like...
David, why is that one so asymmetric?
It's usually asymmetric.
Okay.
So you usually just see it on one side. So it usually floats within the arc of the first rib. It's usually, that's where it is. And it has vague borders to it. Sometimes it has a sharper border on one side than the other. So this is a 25-year-old climbing Mount Rainier from several years ago, and he developed shortness of breath and some confusion. And this is high altitude pulmonary edema, pretty dramatic case of this. And this is actually a kind of alveolar damage. It's not just simple hydrostatic edema. One of the proposed mechanisms is that there is, with a high altitude and the hypoxemia, there is vasoconstriction in the lung because the lung thinks that it's not all parts of it are getting well ventilated, so it tries to restrict circulation because of the hypoventilation. But it turns out that ends up shunting a lot of blood and causing high pressures in the parts of the circulation that are not being clamped down. So it's kind of over perfusion and it's an actual lung injury. There's thought to be alveolar injury. It doesn't clear as fast as ordinary lung edema. So this is what he looked like on day one. And this is day 2. He's cleared most of it already. This is pretty rapid response. So the treatment for this, of course, is to get them down to lower altitudes, and that will go away. And there can be cerebral edema as part of this, associated with this, and people can behave strangely, and it's not a good thing to happen. So it turns out that it's young people that get this. This is not this is these are usually people who are well conditioned, not aging people that might get lung edema from heart failure. And it's probably because the young people have more vigorous vasoconstriction responses to the hypoxemia that goes with altitude. So I was when I was a my first faculty job in my first year, I took a trek in Nepal with a big group organized by an Oakland company called Mountain Travel. And so we were at altitude, and our ship's doctor on this was a guy who was a resident at UCSF. And he began to act very strangely as we were going over this pass at some, I think, about 14,000 feet. And he actually had high altitude cerebral edema. And so we got over the pass, and the Sherpas took him on down pretty quickly to dropped him about 4,000 feet, and he recovered. And he doesn't remember what happened, but he was starting to act drunk. He was our physician. So as I was only a radiologist, that was considered close enough to being a physician. I I I recommended that the Sherpas get him down, but the Sherpas had already figured that out, and they were already trekking him down on the other side of the pass. So it's those young people that get in trouble with this high altitude pulmonary edema. Okay, any questions?
Oh, that's a good.
Okay.
Usually, by the time they get down, they are the better before we get to image them.
Yeah. So that's part of they're very inconsiderate in that regard. Okay, this person had shortness of breath, has a history of losing weight, having some diarrhea, and not feeling well for a few months, worse than the last few weeks, and has these vague lung opacities and fairly low volume. I think this person is around 30 years old. And here's what it looks like on CT. There are all of these sort of stellate, spiculated nodules floating around. And there's a fair amount of sort of amorphous lymphadenopathy here, not well boundaried and stuff like that. So then this fatigue and weight loss, it turns out he has no lymphocytes. And this was Kaposi sarcoma as a presenting manifestation of HIV/AIDS. So pretty spectacular example. The classic finding is for these lesions to sort of be centered around central bronchovascular bundle, sort of extend out from the hyla in a sort of flame-shaped array. And these individual nodules in this person are flame-shaped. I mean, they have ill-defined borders and spiculation and stuff like that. So the lung, this is nodular. It's not really clustering around the hyla to give us that nice flame thing, but the lesions have some flaminess to them. So it qualifies in that regard. So this about a year ago or 2 years ago, we had a raft of about 3 or 4 cases of Kaposi's coming in. So it's not just a disease of the 80s, which it used to be, and early 90s. We occasionally see Kaposi sarcoma as presentation of HIV/AIDS, even in this era. So this is one of last year's cases, I think.
Did he have any extrapulmonary manifestations?
Probably. I mean, they almost always have skin lesions.
Right.
And the
Right.
bronchoscopists, if the bronchoscopists are going after this, they can actually see submucosal, tracheal, and bronchial lesions with this too. And it likes to bleed, so they give those wide berth. Okay. Those are my cases.
Thank you, David.
Those are great. Thank you.
All right, I see Shrav is on. Shrav, do you have any cases this week?
I do, but I have to log into the workstation side of things here.
Okay.
I'm on my laptop right now.
Well, I can show some then. All right. Let's start at this case here. So this is a 64-year-old man with a cough and fever. And on this chest radiograph, you can see he has all of these ill-defined nodules. And there's the lateral, just shows these nodules kind of everywhere. So with that history, you would think infection. A little unusual for most community-acquired infections. On CT, we can see all of these nodules. Some of them are flame-shaped to a little degree, but they're rounder, sort of randomly distributed. There's some mild lymphadenopathy and tiny little pleural effusion on the left. But if we look on the soft tissue windows, you can see there is some low attenuation, so probably some necrosis. So he's immunocompetent. So we would think about things like, at least fungus in particular, around here, histo and blasto. Blasto usually presents as more mass-like consolidation. It's cavitary. Histo is usually clinically silent, or if it's more severe, it's tiny little nodules. But, so he underwent a bronchoscopy, BAL transbronchial biopsy, and this is blastomycosis, which is it's unusual. I've not seen a case present with this many smaller nodules. I've seen a few nodules, and I've seen big nodules and masses, but this one looks more like almost like septic emboli, but they're a little too clean for that. So blastomycosis. It's always surprises me. It always seems to have new tricks up its sleeve. This is an interesting case. So this patient had a defibrillator, and they had to remove it because it was the old generator was no longer working, had been in for quite some time, and they put in a extravascular one. So this is placed retrosternal, and this line comes in through the chest wall, but it's not a transvenous one. You can see there's a remnant of the transvenous lead here. They got the shot coil, the sensing electrode. And so they had to cut this because they were unable to remove it. And what was interesting is these calcifications here, which we just thought were probably related to old histoplasmosis. We see these all the time, some calcified hilar nodes. Now, he ended up getting a CT because they wanted to see all the retained fragments, although usually radiographs are actually better for that because you don't have as much artifact. And what was interesting is the location of these calcifications. If we look, you can see some of them are actually in the pulmonary arteries. They look like calcified thrombus. He had no history of pulmonary embolism or anything like that. And I was looking at these, and they don't even really look like thrombus. They look like just chunks of calcium. They look like calcified lymph nodes, but it hadn't eroded in from anywhere. So I was reading the procedure note for this extraction and replacement of the new pacemaker. Then you can see how they do the extravascular one here. They put it retrosternal. So when they removed the old lead, the reason they had to cut it is because there were heavy calcifications all over the lead because it had been in for about a decade or so. So I suspect when they just embolized when they were trying to remove it. And so those are embolized calcifications on the actual original lead.
So, Jeff, we've had a similar phenomenon. It was reported a few years ago. Calcified fibrin sheaths around catheters that are extracted. When you pull out the catheter, sometimes the little sleeve of gunk that is organized around it, which may have calcifications in it, is stripped off, and you actually can see sort of a tubular arrangement of the calcium. And I think there were some tubular-looking sections when you were showing the CT.
Yeah,
you can actually see that it's a cuff.
Yeah.
So
right
this
here.
This is a cuff. It's a fibrin sheath, calcified fibrin sheath cuff.
But these are quite large, and they actually embolized. I've seen them fixed in the veins before, like the SVC and the brachiocephalic veins from an old dialysis catheter. And I mean, they're stuck in there, but I've never seen one actually embolize.
Well, in this article that I think came from here, I think Greg Kitchka reported this about maybe 3 years ago or so. It was embolic. And we
Interesting.
had before and after, before and after removal of the catheter, this thing appeared when the catheter was removed. It wasn't there before, and it had embolized. So I think this is the same phenomenon, but instead of being related to a catheter, it's related to a lead.
Yeah, it's still a foreign body. Interesting. All right, this next patient is a 57-year-old, and this is an interesting lung. He's got kind of a very complicated picture. So I'll kind of scroll through his lungs first, because I think he's got a couple of different things going on. So you can clearly see he's got fibrotic lung disease down in the lower lobes. But then if you look carefully, as we go up higher, he has some tiny little nodule along the lymphatics. So when I first saw this case, and then he has this dense fibrosis up here, so I thought, oh, looks like PPFE, pleural parenchymal fibroelastosis, very dense fibrosis, some traction bronchiectasis. And then the bases really look like fibrotic NSIP, right? We've got this exuberant traction bronchiectasis, really strikingly lower zone predominant, as opposed to UIP, which we'd expect to be exquisitely, or at least predominantly subpleural. So and I was having a hard time reconciling the two because we often see this with UIP, but less often with NSIP. And then I was trying to reconcile these small perilymphatic nodules that are scattered throughout. And if you look at his mediastinum, he's got these eggshell calcifications, which most commonly we see with sarcoid, but with not a lot of nodules in his lungs. So I did a little digging, and indeed he did work in a foundry. So this is silicosis. And I was trying to decide if I could blame this all on silica exposure. There's some mixed literature about fibrosis, but I suspect this is not. This is probably connective tissue disease and not silicosis. I mean, people have talked about like a fine fibrosis in the bases, but I don't buy it for this. The PPFE is a different story. I don't know if what anyone thinks if this is related to autoimmune disease, completely unrelated, or if this is silica. I just don't see enough high perfusion nodules to think this is all silica related.
It's not pseudoplaque, is it? I mean,
No, it's too
can you
thick.
give us a soft tissue window for that right apical stuff?
Yeah, there's no calcium in it. It's too chunky to be pseudoplaque.
Yeah.
I think he has three different things. There's some of the calcifications that may be from aspiration, but anyway, it was just odd. Sometimes you get these patterns of lung disease, and you have to realize it's not one, but two or three, all and mixed. All right, and then this is a really cool case. This is a 12-year-old who was not thriving, and we have this interesting anatomy here. You can see there's ascending aorta, and here's the left pulmonary artery, and then the right pulmonary artery is here underneath. Seems to come off the main pulmonary artery, and then we can see the aortic root is dilated, and it's sitting right on top of this perimembranous VSD. So this is what is called sometimes a hemitruncus. It's also just a tetralogy of Fallot with an anomalous with the left pulmonary artery coming off the aorta, but it's a conotruncal abnormality that leads to this. So I like the term hemitruncus arteriosus, where you just have one of the branches coming off the aorta, and for some reason, since the pulmonic root does form, and it gives rise. It's a smaller right pulmonary artery, but there's no stenosis of it. It's not one we see very often. I don't know if anybody's ever seen a hemitruncus before. Well, take that as a no.
That's no, that's a really cool case.
Yep.
So
great.
you said he was, how old was this kid?
12.
He's 12?
Well, yeah.
This is nothing diagnosed before, right?
Nope.
This is the initial discovery.
Failure to thrive. You see the child's quite thin.
Yeah.
And I guess, because there's no really outflow tract obstruction, there's probably less cyanosis. There's less shunting. But I mean, the left lung's getting systemic supply, and the right lung is getting the supply. But of course, with the VSD, it's all an admixture lesion anyway. And you can see there's really not dilation of the right heart chambers either. So no RV failure at this point. So very fixable, I would presume.
He's not been taken to surgery yet.
Don't know. I don't think so.
Okay, cool.
Yeah. All right. That's what I have.
Okay, let me share. Let me find the screen first. Here we go. Okay, you can see my screen, I think.
Yes, we
So, okay, thanks. So here we've got, you can already see what I'm going to be pointing at, which is this abnormal filling defect in the left hilum, in the left hilar pulmonary arteries. And you can see that there are some other little filling defects located along the periphery of the kind of main filling defect here. It's resulting in a little bit of dilation of the distal left PA, and the rest of the pulmonary arterial tree is pretty clear. Main pulmonary artery doesn't look particularly dilated, and so it's just kind of isolated defect here. It looks a little irregular and extends into the distal branches. If you look at the lungs, there's a little bit of ground glass. Oops. And we have a couple of nodules here and there. So anyway, this patient, maybe they presented at outside hospital, how these usually go. I assume it was thought to be some sort of PE, maybe treated, and the clot wouldn't go away. And so they transfer them here. And then at that point, we considered the possibility of a pulmonary artery intimal sarcoma. And that's what this ended up being. So now that's not the interesting part. The interesting part comes a little bit later. So then the patient goes on to have a PET CT, pretty probably a year after the intimal sarcoma was resected. The patient had a pneumonectomy on the left. And so here we just see normal, activity along the atrium and come up, and there's no activity at the operative bed or anywhere in the thorax. So looks like a normal, follow-up PET CT.
So I'm not seeing a picture of them.
Yeah, I lost your screen.
Oh, sorry. Whoops.
I mean, I trust you, but I'd like to see it.
Oh, thanks. That means a lot. Let me share again. You let me know if you're seeing.
Yeah.
Okay.
Yeah,
No,
I
yeah.
would do
So
that.
at the operative bed, there's no activity. There's no activity anywhere in the thorax that is concerning. Just post-pneumonectomy changes here on the PET CT. So that PET CT was done in 2020. So let's kind of fast forward here to, well, I guess all we have is this December 2024. So let's take a look at that. So here at this time, we're seeing expected post-pneumonectomy change, including thickening of the parietal pleura here. And we see a filling defect here at the superior aspect of the pulmonary artery, and it looks, fairly hypoattenuating and kind of layering along the dorsal aspect of the pulmonary trunk. And the rest of the, pulmonary artery looks okay. So this is negative at this point.
But wasn't there a
And
nodule in the right lung there?
oh yeah, there was a nodule, and we went in, we did a biopsy, and I think it was negative for malignancy. So anyway, the patient gets, scanned over and over again, kind of cancer follow-up, and we'll just leave it at that for now. This is March 2025.
Yeah, there should be.
So everything looks fairly similar. And, ordinarily I would park it like write on the finding, and I would kind of study that area very carefully, but it's a busy day. You're kind of like going through these cases pretty quickly. And so here you start to see in May of 2025 a little like tiny filling defect here, and maybe that catches your attention. You see it on the next one, like it got a little bigger, and you see it on today's exam, and it got even larger. But you're like, well, this is kind of where the left pulmonary artery stump is located, and it's fairly dark in attenuation. So, it could represent one thing that might come to mind is a stump thrombus. But the question is, we are pretty far out from surgery, and the patient didn't develop stump thrombus early on. But this isn't, I saw this and my mind just went to stump thrombus, kind of blew it off. And then I came back and I looked at the filling defect along the main pulmonary artery. And here you see this starts to look really lumpy here. And then kind of slowing down and looking at everything closely, you see that this area is also, you have lots of convex margin along this region, and there's enhancement. So this is concerning for a local recurrence of that pulmonary intimal sarcoma at the operative site. So that, if you look at it on priors now, compare, I think the most helpful thing is to kind of study this anterior portion, and that has significantly grown from the prior exam to the current exam. And so here we can see it over time. And on some of these exams, this kind of layering hypoattenuating stuff along the superior aspect of the main pulmonary artery looks like it, from exam to exam, it may increase a little bit or decrease a little bit in thickness. And so maybe that throws you off and you're like, well, it's probably just a little bit of thrombus. We're catching it at a funny angle. But that's why it helps to kind of look at multiple older scans and kind of track what's been happening compared to more remote priors. So that's kind of where we are. We don't have any other work up here. So today we are raising the possibility of a local recurrence.
Wow, those are tough.
That's, yeah, I'm not sure. Hopefully, hopefully she's able to get treated.
Yeah, that's fine.
So this next case is kind of along the congenital spectrum here. It's a case of anomalous pulmonary venous return. So we've got a scimitar vein, but that's kind of not the interesting finding here. The interesting finding is actually in the lungs. And so as we come down, we see a little bit of thickening here along the pulmonary fissure, and it's kind of separating the upper lobe, or well, one of the lobes from the other lobe here. And if you look at it, it looks like it's mostly fat attenuation with some vessels coursing through it. But there certainly is, like, you don't see this thickening along the fissure in most cases. So there has been reported, let me pull it up here. There are case reports of this very rare finding called an accessory hemidiaphragm. And so apparently, when they repaired the scimitar vein in this particular case, they found that there was this fibromuscular membrane that contained a little bit of diaphragmatic tissue and almost simulated the diaphragm.
Could you show us that in coronal? That
Oh
would be
my
great in
goodness.
coronal.
Yes,
I
yes,
think,
sorry.
is this the same case Maya showed? I don't think we appreciated
Oh, did
that.
Maya show
I
you?
did show it, sorry.
Oh, you did show it.
Sorry.
No,
Oh,
but
never
no,
mind. Never mind.
No, because we didn't talk about this.
Oh,
no, we didn't
sorry.
talk about
I
this
didn't realize
diaphragm
Maya
thing.
just showed it.
No. We talked about the vessels and the airways. We didn't talk about this finding. You should continue.
Oh, no, yeah. So the fun little finding here, let me share my screen again. Let's go over here, stop sharing, and let me share. I don't know why it keeps doing this. It keeps let's share this one. You let me know if you can see screen here.
See the article.
Yeah, so they, in this article, that when they did the scimitar repair, you see this accessory hemidiaphragm, and they described it as something that kind of dividing the lung into two compartments and kind of running vertically, and it kind of has this anterolateral orientation. And and it sort of looked like the diaphragm. And so potentially that can be a little confusing to surgeons if they open up the case and they find like weird orientation of the diaphragm. And just to understand, like, you know, it's helpful to understand the anatomy and also to the surgeons who then know what to look for in case they need to like resect a lobe or if they need to resect part of a lobe of the lung, is to understand that this could just be an accessory diaphragm and not the actual um, uh, not the actual diaphragm. And I
So,
don't know. Yeah, go ahead.
so is this article, this particular case that you were showing the CT of? Is this article from that case?
No, this is some other article that was published, online, and this case today is a little bit reminiscent of it. I was just
Okay.
describing that the cases, like for example, this article, it seems, if I can zoom in here somehow. Let me try to zoom in for you. So you can see that this area, this where this accessory hemidiaphragm is, there's a little more soft tissue along the fissure here than we have in our case. For us, it's mostly like, looks like in this case that they've shown, there might be some fat or something here in the fissure. For us, it's mostly fat, but it's still thicker than a normal pulmonary fissure.
Very
And
good.
if certain is, if they've got, who knows, things can happen. And if there's like an air leak or something and they don't know where that's coming from, like potentially there's lung behind the accessory diaphragm that's leaking air. If there's some lung injury, or if they need to resect part of a lobe when they're doing the scimitar vein repair, it's helpful to know that, especially if if there's like superiorly, if the fissure is incomplete, that can make things tricky if you're trying to resect a part of the lung along with the scimitar vein.
Got it.
I don't know how commonly that's done, but just good to know the anatomy. I think that's the interesting thing here.
This is a really rare condition in association with scimitar, but there are a lot of misdiagnoses of this in the old literature. In the 90s, I read all of the old articles about scimitar, and a lot of people were making the diagnosis of accessory hemidiaphragm based on a retrosternal stripe that really reflected the mediastinal rotation because of a small right lung. Um, and this was all from the pre-CT days. So there had been an article about accessory hemidiaphragm, and one of the findings was that the person was extremely messed up who had accessory hemidiaphragm and had a small right hemithorax. So